let us recall the ENT part of NEET PG 2020. In ENT there were around 10 clear-cut ENT questions and few questions that were crossover, like there were two or maybe three crossover question in anatomy, they are discussing anatomy, and maybe one question in surgery. So we are only going to discuss the hardcore ENT part. Now let us see what are these questions. Now this is one question where it says the stimulation of the external auditory canal leads to cough due to which of the following nerves, and the choices given by auricular branch of vagus, greater auricular nerve, auriculotemporal nerve, and the facial nerve. For those who know, external auditory canal is supplied by how many nerves? There are 5 nerves in the external auditory canal, in the external ear actually, right? And 3 of the 5 comes from cranial nerve branches, whereas 3 and rest 2 they come from the cervical plexus. Which are these 3 from the cranial branches? One is auriculotemporal, vagus, Arnold's, a branch of vagus, auricular branch of facial. So these are the 3 coming from the cranial nerves, and one is greater auricular and lesser occipital, 5 nerves. So all the choices that were given, all the 4 choices, they were all branches of nerves that supply the external ear. But the question is, which of them causes a cough reflex? Now cough reflex or cough is caused by irritation of the airway, especially larynx and beyond. What is the function of the larynx? You know what is the main function of the larynx? The main function of the larynx is protection of the airway. Airway, it protects your lungs, your trachea and lungs from who? From the foreign body, from the food that goes inside. And how does it protect? Number 1, every time you swallow something, the larynx closes. If the larynx closes, nothing can go inside. But sometimes, despite that, something might, a few drop of water, a small particle may find its way through, and when something goes beyond the larynx or through the larynx, then the second reflex comes into play. For the first one failed now, the second comes into play, and that is a cough reflex. Cough, something gets stimulated. What gets stimulated this time? 8th nerve. Actually your whole larynx is supplied by the 10th nerve, vagus, sorry, did I say it? 10th nerve, vagus. And vagus supplies the larynx via 2 branches. One is recurrent laryngeal nerve and the other is superior laryngeal nerve. So these nerves, they initiate this cough reflex, and because they are branches of the 10th nerve, so any stimulation of the 10th nerve will elicit the cough reflex. And auricular branch of the vagus, so this vagus also supplies a branch to the external canal. That's why the moment you start stimulating the lateral canal, this vagus gets stimulated and the patient might start having cough reflex. And it's very commonly seen, especially when you clean the canal of a patient for foreign body or wax. So when you're cleaning the canal, suddenly the patient starts coughing. It's actually a sign for you to tell, it's sign for you which tells you that you should stop handling the canal. Because when the vagus gets stimulated, cough reflex is okay. But vagus also supplies the heart, and if you stimulate the vagus in the heart, then it causes bradycardia. So when you're cleaning the canal, cough is like a sign that patient might be going to the bradycardia. So it's a sign for you to stop cleaning the canal. That's why the importance of this question. But the answer to this question is, in this case, auricular branch of the vagus, right? Now let us look at the second question. The second question is an X-ray, and this is an X-ray pointed here, and it says steeple sign on an X-ray is seen in which disease. I don't know whether steeple sign was mentioned or not. I think this X-ray was given and they asked that this X-ray is seen in which of the following conditions, and the choices given were acute epiglottitis, laryngotracheal bronchitis, laryngomalacia and laryngeal web. Now clearly you can see this is an X-ray of the neck and the chest, and the arrow is pointed towards this air shadow which goes like this and then straightens up. Right. Now this shape of this air shadow is described as either steeple sign, also called pencil tip sign. You can make out that tip of the pencil looks like this, and steeple, those structures on the top of the churches, they are called steeple. From there you get this name steeple sign. Now the point is, why do we get this shape, this particular shape of the airway in an X-ray? This clearly tells me that the trachea and the larynx has narrowed here. The airway path has narrowed, and this happens because of edema. Edema sets in on the wall of the airway. So because of the edema in this area, the airway has shrunk, and as you keep moving down, the edema part gets less and less wide, and the airway keeps on widening. Ultimately the edema at some point here, the edema has completely disappeared, the width of the airway has become normal. So why I am saying all this, it tells me a large part of the airway is edematous. That's why you get, because at the top the edema is the maximum, that's why the airway is the narrowest, and as you keep moving down, the edema part becomes less and less, keeps becoming less and less as you keep moving down, and therefore the air shadow becomes wider and wider. Ultimately the edema finishes over and the airway becomes normal at this arrow that I have shown. So point is, a large part of the airway is involved to give this kind of a finding, and the large part of the airway, as the name tells us, larynx, trachea and bronchus, everything is involved. So in laryngotracheobronchitis, as the name tells you, which is also called croup, we know this, it's also called croup. So what happens in this, larynx, trachea and bronchus, all the three are inflamed, and the maximum edema is seen in the subglottic larynx. Now why is maximum edema seen in the subglottic larynx, which is roughly, if I may show you here, is the narrowest part of the airway. The narrowest part of the airway is at the subglottic area. This area is the subglottic area of the larynx. Because subglottic area of the larynx, the mucosal lining is very loose, especially in small children. The mucosal lining inside is very loose, so edema can happen very easily and occupy a lot of circumference, narrowing the airway. But as you move downwards from that area, when you go from the subglottic larynx towards the trachea, then the mucosal lining of the trachea is not so loose, the space, submucosal space is not there, so edema, too much of edema cannot happen. So as you keep moving down, the edema keeps on decreasing and the airway keeps on widening. That's why we get this shape, steeple sign in laryngotracheobronchitis. And this X-ray is a X-ray AP view, anteroposterior view you can make out of the soft tissue. It's called X-ray anteroposterior view of the soft tissue neck. In epiglottitis, we get an X-ray of soft tissue neck but lateral view. We don't get it anteroposterior view, we get a lateral view, side view, and everybody knows the epiglottis is swollen, it looks like a thumb, shape of a thumb, and it is called thumb sign, not steeple sign, right? In rest of the two X-rays are not very important, we don't get. In laryngomalacia, we do laryngoscopy, no X-ray. We do a laryngoscopy, that's to direct laryngoscopy, and the finding most of you would know is omega shaped epiglottis, isn't it? And in laryngeal wave, it is endoscopic finding. You find you pass an endoscope or laryngoscope, you can say, and you actually visualize that web. So laryngeal wave, if I draw the vocal cords, the two vocal cords are like this. This is suppose the anterior end of the vocal cord, and this is the posterior end of the vocal cord. and the arytenoids here, let us say these are the arytenoids. So, the laryngeal wave happens in the anterior part of the glottis. Here, this is your web, you can say laryngeal web in the anterior part most commonly. Less commonly it can happen in the posterior part as well, but more commonly in the anterior part. So, this cannot be seen on an X-ray. That is why you have to either do laryngoscopy or fiber optic laryngoscopy, endoscopy, you can say. Direct visualization will show you this. Okay. So, this much about this X-ray. Next one, saccule of inner ear develops from which are the following structures. We all know inner ear is called labyrinth, and labyrinth has many parts. What are the parts of the labyrinth if I ask you? Labyrinth can be divided into 3 parts: cochlea, vestibule has saccule, and utricle, and then there are semicircular canals. 3 canals we all know: superior canal, posterior canal, lateral canal. So, now they are asking about this saccule develops from which part. Now, very interestingly, these 2 parts develop from parts inferior, whereas these things along with endolymphatic duct and endolymphatic sac develops from pars superior. So, saccule clearly develops from pars inferior. You know, if I ask you membranous labyrinth, inner ear, membranous labyrinth develops from which of the following structure? Where does it develop from? Then it develops from surface ectoderm. This is membranous labyrinth. So, in the very early stage of embryo, nearly around 22nd day of intrauterine life, near the cranial end, we all know there are swellings like these projections which are called branchial arches. There are 6 arches, 1, 2, 3, 4, 5, 6. Just behind the second branchial arch, just lateral to the second branchial arch, their depression appear on the 22nd day of intrauterine life. This depression that appear are called on the surface are called otic placard. Otic, so tells us it's going to develop into the ear, otic placard, and gradually this depression keeps on deepening, and then it breaks away from the surface and forms a cyst called otic, either cyst or otic vesicle. So, your labyrinth, the whole labyrinth develops from this structure. So, if I ask you the membranous labyrinth develops from which structure, you can say surface ectoderm or otic placard or otic cyst, otic vesicle is all same thing. Now, when this cyst is formed, I told you it breaks from the surface and goes inside, a cyst is formed that is further going to develop into various structures. The mesoderm around this area, around this cyst, the mesoderm condenses and that becomes the bony labyrinth. So, our bony labyrinth is from the condensation of mesoderm around otic vesicle. So, this is one point, but we are interested in this otic vesicle which separates, I told you, breaks away from the surface ectoderm, and let us say this is a vesicle like a balloon is something like this inside both sides, and then gradually it forms 2 parts. So, this upper part is called pars superior and this lower part is called pars inferior in the otic vesicle. And we know by now that pars superior is going to develop into the utricle, semicircular canals and the endolymphatic duct and endolymphatic sac, and the pars inferior will develop into the cochlea and the saccule. So, the interesting point is saccule, which is from here, saccule is developmentally closer to cochlea, isn't it? They both develop from the same area. So, you can say that saccule is developmentally closer to the cochlea. But functionally what happens? What is the function of saccule? The function of cochlea is hearing, but the function of saccule is balancing. So, utricle and canals, semicircular canals, they develop from the superior part and they are responsible for balancing, and saccule is also for balancing. So, saccule takes up the function of these canals and the utricle, whereas developmentally saccule comes from the cochlea. So, I always say this, that saccule is like a Indian bride. Before marriage she belonged to this family, pars inferior, family of cochlea, but after marriage she shifts to the other family, pars superior, and becomes integrated to that part and causes the function of that area, which is balancing. So, that is how you can remember in a way. So, the answer is pars inferior. Next question. Now, partial closure of the nasal orifice is done which are the following condition, and the answer clear cut is atrophic rhinitis. This surgery is called modified Young's operation. In atrophic rhinitis, which is a very difficult to treat, condition to treat, there are three important surgeries. Surgery is not a very common thing we do, it is not recommended in most cases, but if you do surgery, there are three surgeries. One is Young's operation, the second one is modified Young's, and there is Lawton's-Leger surgery. Now, what is the difference between these three surgeries? In Young's operation, we completely close the orifice of nose completely, and in modified Young's we partially close the orifice. So, when you completely block the nasal orifice, this one, both sides mucosa you separate from the walls and bring both lateral wall and medial wall mucosa and suture them. So, this orifice will complete. If you leave a small gap between that, it is a partial closure and both are done for the same disease. So, when do you do Young's complete closure and when do you do modified Young's partial closure? That depends whether you want to do surgery on both the cavities or one side only. If you want to do surgery on one nasal cavity only, do not want to operate on the other side, then you can close that completely, orifice completely. So, you do Young's operation, that is. So, even if you close one nasal cavity and do Young's operation, the patient will still breathe from the other side. So, that is the whole idea, breathing from the nose still continues. But if you want to do surgery on both the sides at the same time, then in one nose you do Young's, in the other you try to do modified Young's. So, one you close completely Young's, the other side you do not close. If you close both the nasal cavities, the patient cannot breathe through the nose now, the patient becomes a mouth breather, and mouth breathing is never advised. So, what we do is one side, at least one side, you can do in both sides also, but at least on one side you you keep a gap, partially close the orifice, so that the patient continues through that small space, and this becomes modified Young's operation. Lawton's-Leger surgery is a different kind of surgery. In this, lateral wall mucosa is medialized. So, this is what we do in Lawton's-Leger, medialization of the lateral wall of the nose. And atrophic rhinitis is a very important topic. So you must remember the answer is atrophic rhinitis. Let us look at the other choices. Chronic fungal aspergillosis. In this we do a surgery called FES, functional endoscopic sinus surgery. In vasomotor rhinitis, if you have to do a surgery, it is Vedian neurectomy. This is another very important MCQ. The surgery done is called Vedian. You have to cut the Vedian nerve, called Vedian neurectomy. And fungal mucormycosis, we have to do debridement, surgical debridement of tissue, involved tissue, with the help of again same FES, functional endoscopic sinus surgery. So these are the various surgical options for these diseases, but in almost all these conditions except the last one, except this one where surgery is one of the most important treatment, in rest of them surgery is not the first line of treatment. Medicinal treatment is the first line of treatment in all of them. Okay, question number 5 now. Not a surgical landmark for parotid gland surgery. The question is not a surgical landmark for facial nerve, during parotid surgery. This is the question. Oh, right here, facial nerve during parotid surgery. This is the question. Not a surgical landmark for facial nerve during the parotid surgery, because facial nerve, I am sure you know, runs between the superficial lobe and the deep lobe of the parotid gland. And while it is running in the parotid gland, it divides into 5 terminal branches, which are called pes and sarinus. I am writing here. And they finally go and supply all the muscles of the face. All the muscles of the face are supplied by this terminal 5 branch of the facial nerve called pes and sarinus. So a lot of branches in the main trunk of the facial nerve, as well as a lot of branches in the parotid gland, and that's why when you do parotidectomy surgery, chances of facial nerve trauma is pretty high. Therefore, you have to be very meticulous during the surgery. You have to preserve the facial nerve, and there are certain landmarks in the during the surgery that tells you that facial nerve is where the facial nerve is running through. They are like an indicator. While you are doing surgery, these landmarks are like indicator that you are very close to the facial nerve, and when you are close to the facial nerve, you have to be more careful. Right. Now, facial nerve is also running through the middle ear, and while the facial nerve is running in the ear, again there are certain landmarks. So, I will tell you all the important landmarks of the facial nerve in ear, middle ear landmarks of facial nerve, and parotid landmarks for facial nerve. In the middle ear, a very important is called jog, sometimes called cog. Same thing, have 2 different names. Then we have oval window, pyramid. Very important landmark is bulge of lateral semicircular canal, and incus. Incus, the third ossicle, is also landmark, and digastric ridge. These are the surgical landmark of the facial nerve in the middle ear, main, and during the parotid, there are 3 important landmarks: tragal pointer, then posterior belly of digastric muscle, and the branches of facial nerve. Remember, there are 5 branches, so you can identify any branch and follow it back. So, like suppose this is the parotid gland, okay, and let me draw it again. This is the face, and somewhere here is the ear with parotid gland. Now, when the facial nerve comes from the ear and it comes into the parotid gland, one branch goes to the temporal area, zygomatic area, buccal area, mandibular area and cervical area. 5 branches and they are called pes and series, I told you. So while you are doing the surgery, you can identify any of these 5 nerves and trace it backwards, and then you can see the main trunk of the facial nerve you can look at. So this is one of the landmarks, the branches of the facial nerve. So this is the choice D, dissection from the peripheral branches. So what does it mean? Peripheral branches are these 5 branches of the facial nerve. Dissect them and trace them backwards and they will lead you to the main trunk of the facial nerve. The second important thing I want to tell you about this, that when I draw the middle ear cleft, those who have done the lecture, I draw the mastoid like this and then middle ear is drawn like this, this is the middle ear, and in the mastoid tip, this is the tip of the mastoid, there is a groove here, is a groove like this on the medial side. This is the mastoid. What you feel and see is the lateral way. If you go to the middle end, the other end of the mastoid, there is this groove. And why is this groove here? Because from this groove comes out a muscle, and this muscle is the posterior belly of the digastric, and parotid gland is same area. The parotid gland is here, that's why posterior belly of the digastric, and posterior belly of the digastric, mind you, is supplied by a branch of the facial nerve. Everybody knows that. Anterior belly of the digastric is supplied by the mandibular nerve, but posterior belly is supplied by the branch of the same facial nerve. So this becomes a boundary or a landmark for the facial nerve, this digastric muscle. Now very interestingly, before I go to the next one, that this groove through which the digastric arises is called the digastric groove, right? This is the digastric groove. But this same groove, when you look from inside, if you go inside the mastoid and see from inside the same thing, this is now digastric ridge. The same structure from below is groove, from above is ridge. So remember, digastric ridge is also a landmark of facial nerve in the ear. Here, digastric ridge, this one. And from the same digastric ridge, the reverse side of the digastric ridge is the digastric groove, and from where this digastric muscle arises posterior belly and becomes one of the landmarks of the facial nerve. But the most important landmark of facial nerve during parotid surgery is the tragal pointer. This is the most important landmark, because this ear, the outer ear canal is made up of bone and cartilage. The outer part is the cartilage. So the lower part of the cartilage of the canal is triangular. So canal comes like this. When you see from side, the canal is circular, but in the lower part it is triangular like this. It's triangular, and this triangular is pointed towards the facial nerve. If you can see this tragal, this triangular area of the tragus, exactly 1 centimeter, the area where it is, the direction where it is pointing, if you go 1 centimeter to that direction, you will find the facial nerve. So it seems as though this triangle of the tragus is pointing towards the facial nerve. That's why it's called tragal pointer. And this, like I told you, is the most important landmark for facial nerve during parotid surgery. So this is a landmark. I called you digastric posterior belly is also landmark, and dissecting the peripheral part is the landmark. So this is not the landmark, and therefore this is the answer. They are asking which is not the landmark. So inferior belly of the omohyoid comes, inferior belly is below the thyroid, it's here. There is no facial nerve finishes here. There is no facial nerve. Inferior belly of the omohyoid can never be a landmark for, will have no relation with the facial nerve. Right. Question number 6. Question number 6 is, this is an image based question. You can see the X-ray of this area, mastoid area, behind the pinna you can see, and the skin is colored. There is some ecchymosis in the skin, there is some bluish color in the skin, and the question says that patient met with a roadside accident, had a fracture of the skull base or middle cranial fossa, they have written, and they have shown this image. And what is this sign? This is battle sign. Very straightforward, battle sign. Correct answer. Now, what is battle sign? Now, this part of the skin over the mastoid, the blood is carried by emissary veins to the jugular vein. Deep lies behind the mastoid, there is a jugular vein. So, the blood from here is carried by the emissary veins to the jugular vein, and so when there is skull base trauma, this emissary veins gets damaged. So, the blood is not carried by this. So, the blood accumulates here, giving this this color of the skin, and this is called battle sign. So, this sign is indicative of skull base fracture, right. What is the importance of this sign? See, sometimes skull base fracture you can't see nothing, there is a fracture inside, from outside you might not be able to see any signs, there could be no clinical symptom or sign, the patient may be very comfortable, but if you can, and then the risk is that there is skull base fractures are very serious fractures, they are serious emergencies, and sometimes when there are no symptoms and you can't see any sign, you just think that there is no serious problem and you let the patient go home. But if you can see the battle sign, then it tells you that the skull base is fractured and you have to take this patient very seriously. It's a serious emergency actually. So that's the importance of battle sign. You always look for this sign in a patient who had a trauma of this area of the body, but otherwise look innocuous. That means does not look too serious. So that's the importance of battle sign. It's a very important image based question. Let us look at the other options like Bayer's sign. Bayer's sign is seen in two diseases. It is seen in laryngocele as well as Jenker's diverticulum. In both these conditions, laryngocele or Jenker's diverticulum, there is a swelling in the neck. In laryngocele it is in the front, in Jenker's it is little behind, but both are swellings and they are filled with fluid or food also sometimes. So when you shake this swelling, whether it is Jenker's or diverticulum or laryngocele, when you shake the swelling, the collection, the water inside moves and that produces a gurgling sound or water movement sound. This is called the Bayer's sign. When there is a movement sound, that is called Bayer's sign, seen in laryngocele as well as Jenker's diverticulum. Nothing to do with battle sign. There is no water sign, but there is a water X-ray view. We discussed this. Graysinger's sign is seen in lateral sinus thrombophlebitis or sigmoid sinus thrombophlebitis. So again, nothing to do with battle sign or fracture. In in lateral sinus thrombophlebitis, there are four signs: Graysinger sign, there is Tobbe-Ayer sign, Crow-Beck sign, and Delta sign also. Seventh question. Surgical procedure which involves reconstructing the cartilaginous part of the external auditory canal. Canaloplasty, meringoplasty, tympanoplasty, meatoplasty. Now, whenever I start my lecture, almost always the first diagram that I draw, I call it pinna, canal, tympanic membrane, middle ear, inner ear, eighth nerve carries a signal to the brain. So this is pinna. This is external auditory canal. The opening of this canal, this point, this opening of the canal is called meatus, external auditory meatus. Tympanic membrane, I call it meringus, and middle ear is tympanum. Now it becomes very simple. If you do a surgery of the middle ear, you are doing a surgery on the tympanum. You are repairing the tympanum, so it becomes plasty of the tympanum, tympanoplasty. If you do surgery on the tympanic membrane, repair the tympanic membrane, it is plasty of the meringus, it becomes meringoplasty. If you repair the canal, then plasty of the canal, canaloplasty. And if you do a surgery on this opening of this canal of the meatus, is plasty of the meatus, meatoplasty. So canaloplasty is the bony part. We all know canal, if I divide here, this is the bony part of the canal and this is the cartilaginous part of the canal. So when you do a surgery on the bony part of the canal, it is canaloplasty. When you do a surgery on the cartilaginous part of the canal, it is meatoplasty. So the answer is meatoplasty. Cartilaginous part of the canal, which is this outer area of the canal, is cartilaginous part of the canal. This area is called meatus, so meatoplasty. If you go deep and do the surgery, canaloplasty. If you go even deep to the tympanic membrane, meringoplasty, and if you still go deep to that, to the middle ear, it becomes tympanoplasty. This is how you remember the terms. Now, tympanoplasty and meninoplasties are very common surgeries, very commonly done. Canaloplasty is very rare. You don't have to repair canal unless there is a congenital defect, very rarely. But meatoplasty is a very common procedure. Now, can you tell me why is meatoplasty, when is meatoplasty commonly done? Meatoplasty is done at the end of either canal wall down mastoidectomy, either canal wall down mastoidectomy or radical mastoidectomy. So after these two surgeries, which are common surgeries, this opening of the canal has to be widened. That becomes a meatoplasty. That's why this name is important at the end of the mastoid surgery. But if you remember these terms, then it becomes very easy to know in which part of the year what type of surgery is done. Eighth question, next one. Now, this is an image based question. As you can see, this is an image of a oral cavity and oropharynx, and the question says a patient present with fever and difficulty in swallowing, and they are asking for diagnosis. What do you see in the image? You can see the tongue here. This is the tongue, right? This one is a palate area, soft palate especially, and this is the uvula. Can you make out the uvula is pushed to one side? This side where the uvula is pointing or pushed, the tonsil looks normal, but the other opposite side tonsil is enlarged. So let me use a red color here. So this is a enlarged or pushed tonsil. Also the uvula is pushed. The patient has fever and difficulty in swallowing. This is a clear-cut case of peritonsillar abscess, this one, which is also called quinsy, and it's caused by streptococcus, right? This is an abscess. This is an abscess of peritonsillar space. And where does the peritonsillar space lie? It lies between capsule of the tonsil and superior constrictor muscle. Superior constrictor muscle is sometimes called the bed of tonsil, right? It's a very painful disease. Patient cannot swallow properly, cannot speak, fever, and this condition is compared to a hot potato condition. Because of the enormous difficulty that it poses, that's why hot potato condition. And the treatment is immediate drainage of the peritonsillar abscess. The main differential diagnosis is parapharyngeal space abscess. Parapharyngeal space, as the name tells you, around the pharynx. Both sides there is a space called parapharyngeal space. It's a inverted pyramidal shaped space, and the abscess of the space is very similarly presents very similarly. The main thing is that in a parapharyngeal space abscess, the tonsil does not get pushed so much, because imagine there is in the soft tissue of the neck there is an abscess, so it tends to put the soft tissue of the oropharynx inward and the skin outwards, so it has more space to stretch itself, so it does not push the oropharyngeal soft tissue or tonsil too much. Instead, it will push the skin of this area also outwards. That's why behind this angle of the mandible in a parapharyngeal space abscess, you can see fullness or slight bulge. That's a very important finding in a parapharyngeal space abscess. More than inside, there is a swelling outside in the parapharyngeal space abscess. Yes, there is some swelling in the oropharynx also, pushing the tonsil immediately, not so much I said. Certainly not the uvula. Uvula by parapharyngeal space cannot be pushed like in this case. Uvula pushed means it has to be a peritonsillar space abscess or quinsy. That's a very important finding in this. Retropharyngeal space abscess is behind the pharynx. Retropharyngeal space, as the name tells you, is behind the pharynx. So lateral wall of the pharynx will have no problem. The bulge is seen on the posterior wall. Otherwise, there is fever and dysphagia, yes, but the bulge is on the posterior wall of the pharynx, not from the sides. So clearly ruled out. And Ludwig's angina is a cellulitis of the submandibular space. Cellulitis, not abscess, of the submandibular space, which is between the floor of the mouth and this. There is a space called below the mouth, that is called submandibular space. When there is an inflammation, cellulitis, that becomes Ludwig's angina. So again, nothing on the sides. So it's a very clear cut diagnosis, peritonsillar abscess. Rest of the two I told you, Ludwig's angina and retropharyngeal space, can be ruled out easily. The only problem could be parapharyngeal space abscess. Uvula will not be pushed in parapharyngeal space abscess, tonsil does not get pushed so much, and there should be some swelling or fullness behind the angle of the mandible from outside also. Next, question number 9 is, tubercular otitis media is characterized by all except. That means 3 are true, 1 is not true. You know what is the classical feature of tuberculosis of ear? The classical feature is multiple perforations, and this is very commonly asked in the exam. So if you have a tympanic membrane like this, handle of Malleus, and on this tympanic membrane, if you can see many perforations, more than 2 perforations, it is clearly a case of tuberculosis. The second most important feature is pale granulations. Now granulations in the middle ear is a pretty common finding, and you have to look at the color of the granulations. If it is pale in color, it is tuberculosis. If it is red in color, it is unsafe CS swim. Red granulations in unsafe CS swim, pale granulations is tuberculosis. And if you see granulation in the external ear, this is both middle ear I told you. If you see the granulation in the external ear, then it is malignant otitis externa. Again, it's almost a diagnostic finding in malignant otitis externa. So look at granulations in the ear, so important. Granulations in the external ear, almost diagnostic of malignant otitis externa. Granulation in the middle ear, pale in color, a very important finding in tuberculosis. And granulation in the middle ear, red in color, a very important finding of unsafe CS swim. So extremely important, this finding. And discharge may or may not be foul smelling, but it is watery. There is no pus. In tuberculosis, we know there is no pus. It's a watery, serous discharge from the ear. But the most important feature, which is another very important, there is no pain. Ear tuberculosis is painless. So no painful otorrhea. So this is not true, and this is a correct answer. Now, tuberculosis in ENT affect 2 areas very commonly. Among the ENT areas I am talking about, ear and larynx. Ear tuberculosis, laryngeal tuberculosis. What is interesting is, ear tuberculosis is painless, like I told you, and laryngeal tuberculosis is very painful. So that's how you remember in ENT: painless tuberculosis, painful tuberculosis. And multiple perforation I told you can be seen on otoscopy, is a diagnostic finding. Facial palsy is the most common complication, and treatment is, first you treat tuberculosis with antitubercular therapy. That's the main line of treatment, antitubercular therapy. Once you control the infection totally, then you have to repair this perforation with meringoplasty. Remember, I just told you that repair of the tympanic membrane is called meringoplasty. So that's all you will do to repair this. And the last question in this series is, oxalomental view with mouth open to check the PNS, basically nose and sinus, is called what? What view is this? Now this is, I can say, a tricky question. If you only take a occipitalo-mental view without open mouth, then it is Waters view. So if it is occipitalo-mental view only, or occipitalo-mental view without open mouth, then we call it Waters view. But if it is with open mouth, like in this case it was with open mouth, then it is Perez view. So this is the correct answer, Perez view. Now why I told you this is a tricky question, because this view, if you read your books, if you even if you go to clinical practices, nobody writes Perez view. Even many radiologists, not radiologists, but the radiological technicians who do radiographs, ask them, they will not know what is Perez view. So we call it Waters view. Commonly the same view, occipital mental view with open mouth commonly is called Waters view. What I am trying to say is, if they ask you the same question, that occipital mental view with mouth open is what view, and if Perez is not given in the choices, if this is not given in the choices, then you can accept Waters view as the correct answer. But if Perez view is given like in this case, then what Perez view is the better answer and correct answer, Waters view is not a correct answer. But the both serve almost the same purpose. Now, what is the main advantage of this view? Waters view shows all the sinuses, Perez view shows all sinuses, plus sphenoid is very clearly seen. So we keep the mouth open for sphenoid sinus. Through that gap, you can see the sphenoid very nicely and right in front. So that's the advantage of Perez view. Cardwell's view is AP view, antero-posterior view, straight, and this is for frontal sinus. And Townes view is for mastoid, not PNS, it is a mastoid. So it's a lateral oblique view, it's like lateral oblique view. No, it is not, sorry. The lateral oblique, for mastoid we do two views. One is lateral oblique view, which is called Schuller's, and the other is from the front again, which is called Townes view. So for mastoid we always ask two view, always. We don't get one extra view, we ask two views. One is Schuller's view, one is Townes view. So Schuller's is lateral oblique view, that will show you the mastoid, and Townes view is taken from the front. This Townes will compares the two mastoid. You can see both the mastoid in one extra film, and it compares both the mastoid. And so X-ray views in ENT, these ones are pretty important. You must know all of them thoroughly. So this will complete all the important questions from ENT that came in NEET 2020. Thank you.